Well, good evening, everyone, and welcome to tonight's Goodfellow Unit Webinar on the non-pharmacological management of musculoskeletal pain. My name is Dr. Hazel Fuyava. I'm a GP in South Auckland, and I'm the Goodfellow Unit Co-Deputy Director. Tonight we have Professor Duncan Reid with us, and I'm just going to introduce Duncan before he starts speaking for us. So Duncan is a Professor of Physiotherapy within the Faculty of Health and Environmental Sciences at the Auckland University of Technology. Duncan has 42 years of clinical experience in musculoskeletal and sports physiotherapy. His main areas of interest are in manual and manipulative therapy. His research interests include management of knee injuries, and Duncan completed his doctoral thesis investigating the effects of lower limb stretching interventions on patients with osteoarthritis of the knee. Duncan's experience in sports physiotherapy is very extensive. He has been a member of the Olympic and Commonwealth Games medical team from 1988 to 2000, and he was the chief physio in 1992, 94, and 96 games. Duncan is also the physiotherapy advisor for High Performance Sport New Zealand, and he also has over 200 peer-reviewed journal and book publications, and is on the editorial panel of the Journals of Musculoskeletal Science and Practice, Manual Manipulative Therapy, and the Journal of Orthopedic and Sports Physical Therapy. And therefore, with that very impressive resume, we're absolutely privileged to have Professor Reid speak for us tonight on managing musculoskeletal pain. So I'll hand over to you, Duncan. Thanks so much.
Kia ora koutou, everybody. Thank you very much, Hazel, for that kind introduction. So as you're aware, the topic tonight is non-pharmacological management of low back pain, neck pain, lateral elbow pain, and osteoarthritis of the hip and knee, and clearly a very popular topic. So I'm somewhat intimidated by the number of people who've signed up for the webinar, but equally excited by the opportunity to talk to my general practice and other medical colleagues. So as Hazel has pointed out to you, I do have a little number of years of background in musculoskeletal practice. I had a private practice in Morrinsville for a number of years, and interestingly, in context for this presentation tonight, not long after I'd moved to Morrinsville, the general practitioner team got in touch with me and said there's two problems which we struggle with every day, and they are tennis elbow and low back pain. So it's timely that we should sort of go back and revisit this. If I knew then what I know now, I'm sure some of my patients would have got a lot better. But my other message tonight is this is a great opportunity to talk about what happens in physio land and hopefully increase general practice integration. I think general practice and physiotherapy, private practice, have probably grown a little bit apart since physiotherapy got primary referral way back in the 80s and early 90s. In more recent time, as I was on the slide there, I have been in an academic role, but I also teach a postgraduate musculoskeletal and sports physiotherapy paper. So I think of myself as an academician. I still see patients, and hopefully that's tonight's message, that there are some practical things we can take away. So the aim of tonight is to provide you with some structure of how to manage these musculoskeletal conditions in a non-pharmacological way, with the brackets for some conditions, because there is a place for some medications in the overall management, and I'll try and allude to that as we go forward. And I'd like to increase this ability to work more closely with your physiotherapy colleagues. So what does an orthopedic manual physiotherapist do? They certainly are an area of specialization within physiotherapy, and they look at neuromusculoskeletal conditions based upon a very strong clinical reasoning model that we teach at the university. They have a highly specific treatment approach, including manual therapy and therapeutic exercise. And they do this within the available scientific and clinical evidence in a biopsychosocial model. So we like to think that we're reasonably holistic and that we can get to the bottom of what that patient needs in that interaction. So one of the things that I've learned over many years is to be a good physiotherapist, you need a big toolbox. You need lots of things to manage the people that come in your door. You need a pretty good dose of pain science, soft tissue management, cognitive re-education, exercises, which is a big part of physiotherapy, neural mobilization, a very good assessment, and the area that I've spent a lot of time doing, mobilizing and providing high velocity thrust to some patients, and a big dose of education. So tonight is an accumulation of my years of knowledge to try and impart to you things that I think are useful in managing these types of conditions. And there is an imperative to try and manage these conditions, because if we look at the years lived with disability, low back pain, neck pain, and other musculoskeletal conditions sit in the top 4. So we're not going to be short of these types of patients, and they do make up a fairly big chunk of physiotherapy practice, with about 60% of physiotherapists working in musculoskeletal private practice. And I suspect a fair chunk of people that walk in your door have some form of musculoskeletal condition. So let's get underway and talk first of all about low back pain. Now, this is quite a busy slide, and I have provided this as a single slide for you to look at later on. And I'm not going to dwell on every single box that's on this slide, but I just want to point out to you that the journey for someone starts obviously with the first visit and taking a clear history, which you're all very capable and skilled at, and then removing the red flags off for further assessment. So significant fractures, things that are covered in the ACC's acute low back pain guidelines, such as cauda equina, history of cancer, etc. Once we've got rid of those more challenging conditions, then often these people are presenting you particularly acutely in a very inflamed condition, in which case, going to a little bit of the misnomer of the talk, is that these people do need a bit of chemical management. They will need some reassurance. They'll need perhaps some low-level analgesics, paracetamol and non-steroidals, just to get the chemical reaction settled down. And so if we move through that sort of triage process and they're now becoming a little bit more mechanical in their presentation, then what I'd like to focus on tonight is the bottom right-hand corner of this slide. And I've tried to classify for you the types of conditions that we would see. So what we're calling a centralizer, a sacroiliac joint pathology, a symptomatic stiffness person, and we'll cover the postural and acute pain with regards to neck and back pain. And I do need to give recognition to my colleague, Steve White, who works with me at AUT, and he has developed this slide to teach our undergraduates and postgrads how to work through the mire of managing low back pain. This is a pathoanatomical diagnosis and a category-based diagnosis. But even before we go down into that pathway, I'd just like to give you an opportunity to think about a tool which is good at risk stratification. And one of the things we have to do when people hit primary care is see if we can reduce the number of people who become chronic. So in order to do that, we need to see what the potential risk is going forward. Now, some of you may be aware of this tool called the StartBack tool. It comes out of Keele University, but it's been very helpful in the national health system to be able to manage the risk. So if people fill in this tool, which I'll show you in a minute, and they have low risk back pain, they should be given good advice, pretty much as per the ACC low back pain guidelines, reassurance that they're going to get better, some simple analgesics, and off they go. In New Zealand, they'll probably get maybe 4 or 5 physio visits. In the medium risk group, they need a bit more intervention with the evidence-based care of manual therapy and exercise, and they may have up to 10 to 12 visits. And then there's a very small group who've got some significant biopsychosocial problems who need a different approach. And they can be managed by physiotherapists who do have those skills, or you might need to call on your psychology colleagues to help manage these people. Now, you may not be able to see the absolute questions on here, but it's a very simple tool to fill out. It would probably take a patient 1 or 2 minutes to do this, but it'll give you a very good trajectory going forward. So the questions are things like, my back pain has spread down my leg at some time in the last 2 weeks. I've had pain in my shoulder and neck sometime in the last 2 weeks. I can only walk a short distance. I've dressed more slowly. Have worrying thoughts about my back pain. My back pain is terrible and I'm never going to get better. In general, I'm not enjoying the things that I used to enjoy. So you can see as you go down the 9 questions, they become more and more focused on some of these biopsychosocial barriers to moving forward. And so once you've filled out the score, you get the risk stratification on the left-hand side. So in the UK, the GPs have been using this tool to manage the trajectory into physiotherapy, particularly sending people with the medium to high risk in for care. The impact of the StartBack tool has shown that there's 50% fewer days off work because people are not being catastrophized around their low back pain, and fewer sickness certificates are being issued because they've been given good advice and told, for many cases with not particularly challenging back pain, that they will get better and everything will be okay. Now, we haven't implemented this in New Zealand. It has been discussed with ACC, but that doesn't stop you as a general practitioner or primary contact practitioner using the tool to determine what might be a good trajectory for that patient. Now, the other thing that's helpful to have a little bit of understanding, again, going back to sort of more of a biomedical diagnosis, is what is the prevalence of the things that you might see. So in the age range between 20 and 40, you're more likely to see people that have got some sort of disturbance of the intervertebral disc. As you get into some populations, particularly the female pregnant population, you will of course see more sacroiliac joint presentations. And in the older population, as the spine ages, you're going to see more facet joint presentation. So just having that knowledge that this might be the prevalence of the conditions you will see gives you some sense of what might be happening as that person walks in the door. So let's talk a little bit about acute low back pain. Some of these people present with quite a bit of distress, and some of them will present with this thing called a lateral shift where they're off center. And a New Zealand physiotherapist, Robert McKenzie, was at the forefront of developing a range of exercises which are shown on the right-hand side of this slide to correct the shift and move someone back into extension, because a lot of these discogenic presentations are precipitated by flexion and lifting type activities. Other thing which is really helpful to understand is this phenomenon called centralization or peripheralization. If the pain is moving away from the back and down the leg, generally things are not going well. The exercises that McKenzie promulgated allowed the skilled therapist to guide this person in such a way that they could bring the pain back to the center of the back. And once it did that, it tended to settle down quite quickly. So this is a very common acute management strategy, and most physiotherapists are trained in the McKenzie protocol to be able to manage this phenomenon. Sacroiliac joint. How would we determine if this is a sacroiliac joint problem to start with? Well, the first thing is to determine where the pain is. If it is midline, symmetrical, and above L5, with or without nerve root compression, and we go through this repeated movements examination and the pain comes into the small of the back again, then the likelihood is that this is a symptomatic disc lesion. Now, if the pain does not come back into the back above L5 and is still predominant in the buttock, then Mark Laslett, another New Zealand physiotherapist, developed a set of provocation tests, of which there are 6, which give you a higher probability of determining that the sacroiliac joint is the source of pain. And if you have 3 positive tests, then that's a symptomatic sacroiliac joint. If you don't have 3 positive tests, then the next possibility is this could be a lumbar facet joint, hip joint problem, or gluteal tendinopathy. But on the slide here before you are just this test that a physiotherapist skilled in this area would do. So on the left-hand side, we have the distraction test of the sacroiliac joint. On the right-hand side, we have a thigh thrust test, which is a very sensitive test, particularly if you've got a sore sacroiliac joint. And then we have a compression test, a sacral thrust, and a stretch that looks a bit like a hip flexor stretch, but it's really just rotating the pelvis one side and the other. So those are the test sequences that someone would go through to determine that you've got a painful sacroiliac joint. Now, that's helpful to know that your sacroiliac joint's painful, but who are the people who are likely to have it? So we've already mentioned that you could be pregnant, and these people in the course of trying to have a baby have lacked some of the normal mechanisms which hold the pelvis together. So they've got a problem with loading through the pelvis. These people could benefit from a belt and some activity modification until they've had the baby. But afterwards, they might need some exercises to help to strengthen the lumbar spine and the pelvis. There's a group of people who are going to present with inflammatory sacroiliac pain, and these are most likely to be the ANC-SPOND group. So we need to make sure we've picked up those people, run some blood tests with them, but they should be behaving as a spondyloarthritis. And these people might need onward referral to the rheumatologist. If it's an inflammatory problem from a trauma, then again, we can offer some early protection and then move into rehabilitation. And then there's a small group of people who will have had a trauma, often the rugby players, the mountain bikers who've fallen onto the pelvis, and they're going to go through a normal process of getting repair and regeneration and getting back to normal mobility. So that gives you some sense of the types of presentation that SIJ might have. Now, physiotherapists do have a range of other skills, mostly following another New Zealand physiotherapist guidance called Brian Mulligan, and he would do some mobilization with movement to help restore normal function to the sacroiliac joint. So the next group on that very busy slide was the symptomatic stiffness group. So how would you recognize someone has symptomatic stiffness? These are mostly into 2 groups. One is the post-traumatic group. These people have had some sort of trauma to the spine. We'd expect it to go through a normal healing process, but the soft tissues, particularly the capsule and the ligaments around the bone or the bone itself may have left them with some stiffness over a period of time. And these people need a fairly targeted treatment regime of mobilization exercises. The other group is the stiffness associated with disease processes such as osteoarthritis. And these people are having change over time. And again, they can respond well, as we'll discuss later today, around mobilization exercises and appropriate management. So there are a range of hands-on techniques that physiotherapists can employ to manage symptomatic stiffness, moving the joints of the lower spine, including mobilization and manipulation. So that's a whistle-stop tour through the lumbar spine, but as we come into the neck, you'll see there are some similarities in terms of how we manage these types of spinal condition. So again, I've got a flow diagram for you which sort of guides you through the process. So if someone presents with neck pain, we take our history and we try and eliminate the red flags. So in the neck, we have category 1 red flags, which is your fracture group, which you would apply your Canadian C-spine rules to and see if they need a medical referral for x-ray and intervention. The second group are those people who've had some vascular event, maybe a trauma to the vertebral artery, or they've had a ligament rupture in the neck, where a physiotherapist will do some other more definitive testing to see if they need to be referred on. And there are those patients, as in the lumbar spine, who are going to present with some sort of neurological, radiating arm or leg pain, and they might have a radicular pain or radiculopathy or spinal stenosis, or maybe even in some rare cases, as we know, a tumor. So once we've worked through that, if we've got that out of the road, but we've got the more chemical orientated presentation, then we're going to have to refer our patients to you as physiotherapists because we cannot prescribe. So we again look for some reassurance, some analgesia to get them to settle down. And then once they become a little bit more mechanical, then we'll go through our movement examination. And the categories are somewhat similar to the lumbar spine. We're going to have a stiffness group, we're going to have a cervicogenic headache group, an acute group, which I'll refer to sort of as the whiplash group, and then the postural group, which is pretty prevalent in our somewhat more static society these days. So let's look first of all at symptomatic stiffness. Well, clearly they're going to be the same body of people who have had the lumbar spine condition, so the post-traumatic group and the disease group who may have some spondylosis in their neck. These people will present with acute neck pain, often less than 6 weeks duration. It'll often be unilateral, and they'll have limited neck movement and limited movement potentially of the thoracic spine. The movement will be produced where they get towards the end of their available range, and if you palpate the joints of the cervical and upper thoracic spine, they're often tender on palpation. So the interventions for the stiffness group are in initial stages. The physiotherapist may actually work on the thoracic spine because there's a regional interdependence between the thoracic spine and the neck itself, whereby treating the thoracic spine, you can improve range of motion in the cervical spine without causing too much pain in that area. But as they settle, then the techniques should be targeted more directly to the cervical spine, followed by stretching exercises and strengthening exercises to the muscles that support the neck. So basically range of motion and movement are the keys for getting rid of the stiffness. These people will need to understand they need to manage this over time. Now the headache group, many of you will be familiar that the 3 dominant types of headaches that we see in primary care are cervicogenic headache, tension type headache, and vascular headache, with migraine as the surrogate for that group. And the tension type headache and the vascular headache are the ones that are more likely to have a medical intervention. The cervicogenic group is a much smaller group, but they are the ones who are responsive to physiotherapy. The tension type headache group can respond to physiotherapy, but because it is, as the name says, tension, then life stresses and other psychosocial variables do need to be addressed. Just treating the symptoms of tension type headache doesn't usually see a good resolution. So I've got this slide for you there just so you can get some sense of the variables of how these different headaches present. But I'll just focus for now on the cervicogenic headache. So this is a non-continuous unilateral headache where the pain is coming from the upper 3 joints of the neck. The headache is usually precipitated or aggravated by neck movements or sustained positions. They'll have a limitation of the upper cervical spine movement, and particularly the segments between C0 and C3, and is often provoked if you palpate those particular segments and the trigger points associated with the muscles that cross the neck. They've often lost strength and endurance deficits in the neck with the typical, what we would call forward head posture, which is a posture that sadly we've all been in at some stage in our lives, but perpetuation of that posture can help to precipitate the headache. So if we look to some evidence to say what is the best management of cervicogenic headache, this is a study undertaken by a colleague of mine, Gwen Joel, in Queensland. This is an old study, as you can see, 2002, but it is a seminal study and has never been improved on. So this study was a multi-centre trial with 200 subjects where people met the criteria for a cervicogenic headache. They were given a range of 4 options they were randomly allocated to. Manual therapy, which included mobilisation and or high velocity thrust plus exercise, which was a deep cervical neck flexor exercise. Manual therapy alone, exercise alone, or a control group that had GP care, which was analgesia and advice on the management of headache. Now, the outcome of this study is that the combination of manual therapy and exercise saw a greater reduction, 50% headache reduction in a reasonably large percentage of these people, and 100% reduction in a smaller number. And the control group really didn't change too much. So the headache frequency and the improvement was much better in the group that had a combination of manual therapy plus exercise. And in fact, those people who did their exercises had a much longer duration of response from the headache, and a year down the track, they were much better off managing their own headache. So this is some pretty good evidence that the interventions with which a physiotherapist can provide is going to give you some good relief of your cervicogenic headache. Now, on to the next group, which as the acute neck pain group, which we're going to use whiplash as a surrogate for that. Now, we know that whiplash is not a diagnosis, it's a mechanism of injury, that multiple structures can be damaged, but it often creates quite a bit of anxiety. These people can be left with post-traumatic joint stiffness and restrictions of range of motion, and they can do some damage such as ligament injury and or fracture. So if we go to how to overall manage these people, then the Quebec Task Force has given us a form of classification where they've said that if you've had the event but you don't have any physical signs or symptoms, then that's a 0. If you have some neck complaint and some local tenderness but no other physical signs, you're categorised as a 1. A group 2 would be that they've got a neck pain complaint, musculoskeletal signs, and decreased range of motion in the neck. Group 3 has the same but with a neurological impact with some radiating arm pain. And group 4 has the same complaint but with some more severe outcome, which is a fracture. Now, most of these patients between 0 and 2, and some of the 3s, can be quite easily managed within primary care and physiotherapy. And the key messages that we want to give these people is that serious injury is rare, and if we have screened them for the risk of fracture, etc., then we should be sending those ones on, and the rest should be having reassurance that the prognosis is good, that self-exercise and manual therapy is helpful, and that positive attitudes and beliefs that regaining activity levels are going to be a part of their management. Now, it does say over-medicalisation is detrimental. I don't think we see a huge amount of that in New Zealand, but in some other countries, particularly where they've got lawyers involved, then that does tend to be a problem. Collars has been a bit controversial. I think if I'd had an acute ankle sprain, I'd quite like to have a supportive strapping or a brace on it for a short period of time. I think a collar is of some value for people that are quite acute following this, as long as they understand that this is a temporary measure and that they should be basically moving and getting back into their normal activities reasonably quickly. So what is the evidence around the management of whiplash up to level 2? So this is a systematic review done by Alison Rushton from the UK, and a number of studies were involved in looking at short-term pain and range of motion with these people that have had a whiplash. And there is certainly some reasonably good evidence that there is improvements in short-term pain and range with physiotherapy. So it is important to get these people to the physio to get the management of their movement back and up and running. Next group of acute patients that we see is the people who present with cervical radiculopathy. Now, these patients are mostly in their 50s, which might make you think that the potential cause of the radiculopathy would be some changes in the joint space in the neck, but we can have disc herniation, osteophytic encroachment, trauma with particularly the fracture group, and the odd person that has a tumor. Now, the picture on the right-hand side of the slide here is a typical presentation. This person has often had 3 or 4 nights of no sleep. They're pretty grumpy with this very debilitating arm pain, and they put their hand on top of their head because that takes the pressure off the C5-6 nerve root, and that's probably how they have been sleeping over that period of time. Some of them will have quite significant weakness. Some of them just have persistent pins and needles and tingling down the arm. So these people do present through these range of reasons, and so they get this neck pain with radiating arm pain in quite a narrow band, which is your typical radicular pain, upper extremity paresthesia. They're generally aggravated by anything that takes the neck towards the painful arm, so tipping their head to that side, turning their head to that side, or putting axial compression through the neck will produce the arm pain. Physiotherapists have a range of tests they can do that look at nerve movement through the neck, and those are often positive, and distraction or traction can often relieve the reported symptoms, but for a very short period of time. So what is the management for that? Well, in the acute situation, again, reassurance that everything is going to be okay. Again, I think a collar, even though I've got it on the slide there, I think they can be useful in some people, particularly if they wear the collar in such a way as it keeps the cervical spine a little bit side flexed away from the painful side. And then they need to undertake a range of exercises and mobilization techniques as the pain begins to settle. Is there any efficacy for this? There are a couple of reviews around the use of manual therapy, but in the end, the level of evidence is not particularly strong at this stage, but it does recommend that mobilization and exercises are helpful, and probably as helpful as wait and see. My personal experience of these patients, because they're very distressed at the time, is this is a good example where I think there's a combination between pharmacological and non-pharmacological approaches. I treat these people in the first 4 to 6 weeks as being highly inflammatory. Now, in the absence of something really serious, like a fracture or a tumor, ability to control the swelling around the nerve root seems to be quite paramount. Now, we can start them off with the analgesic pyramid, and we start them with Panadol and non-steroidals, but sometimes that doesn't touch these people's pain. We don't want to go to the really high-end drugs such as the OxyContin and the Tramadols if we can avoid it, but I have had some success working with my GP colleagues to give these people, if medically appropriate, a short burst of prednisone, oral prednisone, because again, that has a strong anti-inflammatory effect. If this was a lumbar spine patient, they'd probably be a potential candidate for an epidural steroid, but getting an epidural steroid into the neck is a little bit more delicate than into the foramen of a lumbar spine. So oral prednisone may be another option to consider as long as they're medically capable of taking that. And then once they've settled down, they're starting to sleep a bit better, then we can move into the exercises and the mobilization as recommended by some of these guidelines. A small number of patients will have a osteophytic fragment that needs to be removed or a disc fragment, and they will be resolved by a conversation with our orthopedic colleagues. Now, postural pain, we all are victims of sitting at our computers for too long, and so there is some reasonably good evidence that postural neck pain is associated with sustained static loading of the cervical spine and the shoulder girdle. And so on the picture before you, you can see there's an image of a gentleman where if you look down the slide, there's an A in the middle of his head and there's a C in his ear. That's the tragus of the ear, and you can see D is the cervicothoracic junction. Now, forward head posture is defined as C moving quite a long way forward from D. And this is what we see with these people. They tend to move into upper cervical extension and low cervical flexion, and they get this increased thoracic kyphosis, which some people have often called a dowager's hump. But that's a function of sometimes sustained postures, and particularly in jobs where people have been sitting at computers for a long period of time. So you will get a lot of patients who will present with musculoskeletal discomfort and headache as a consequence of this. So the headache slides that I showed you can help to manage the explicit headache. Often with the patient who's in these difficult workstation positions, we can use our occupational therapists to get some workstation assessment, but giving people some fairly straightforward advice, looking at the sitting position of their chair relative to their computer screen. I like to give them these pause exercises where they get up from their static positions every 20 to 25 minutes and do some range of motion, some stretching exercises, cervical retraction and upper cervical nodding to get the head moving helps to manage that headache, and stretches to the neck and the forearms, particularly some of those neural stretches can be quite helpful. Now, there's quite a lot of advice on this on the OSH website, and some of you may well be already well aware of this and give your patients this type of advice. But really, they need to understand that the outcome is in their hands as to how long they're going to sit in a sustained position before they start to get uncomfortable. So that's pretty much covering the lumbar spine, excuse me, and the cervical spine. And we're now going to move on to tennis elbow. So tennis elbow is defined as pain over the lateral epicondyle or lateral epicondylalgia. It's usually a activity-based problem where people have got pain with resisted gripping activity. Obviously, the name is reflective of tennis. It's a gradual onset condition sitting in the age group from 35 to 50 years of age, and the incidence varies depending on the activity. So in the general population, it's around about 3%. In the sporting and the workplace manual workers, it's probably up to about 15%. These people will have symptoms anywhere between 6 and 24 months, but the majority of these people do recover within 1 year. But during the time that they're obviously presenting, they're pretty grumpy and they want to get their elbow better. So ACC developed a upper limb guideline in 2009, and they chose to continue to use the word epicondylitis, which is of course reflective of an inflammatory itis model. But there's pretty good evidence that this inflammatory model isn't really the deal, and these people have more of a tendinosis type pathology where you've got changes within the tendon structure. So whilst that guideline did use that, I think our patients would be much better served by telling them that they've got changes in the tendon related to changes in loading parameters that they've been doing. So the diagnosis is palpation over the lateral epicondyle and resisted wrist extension or middle finger extension, which is Cosen's test. There hasn't been any other literature to suggest that's any better at this time, so it's not a difficult diagnosis to make, except that I would suggest that you check the neck and the nerve tissue down the arm to make sure you're not missing a referred pain from higher up, because sometimes that can be mistaken by the patient who keeps pointing to their elbow but doesn't realise that the pain is coming from their cervical spine. So what does the guideline say about the treatment? Well, there's level B evidence for physiotherapy, watchful waiting, a cortisone injection, bracing and taping with lower level evidence. And what I'd like to present to you tonight is really the fact that the treatment should be developed into two parts. Firstly, the pain management part, and then the load management part. So there is a very elegant study done by some colleagues of mine in Australia, Leanne Bissett, a little while ago now, but again, one that hasn't necessarily been improved upon, which used some of the evidence from these guidelines to compare physiotherapy with cortisone with the wait and see approach, which was general practitioner care. So this was, again, a multi-centre trial with reasonably large numbers, around about 65 people in each group. So the wait and see group were given advice, analgesic medication, heat or cold, and the use of a tennis elbow brace. The second group was given 1 to 2 cortisone injections with a return to work plan. And the third group were given a Brian Mulligan manual technique called a mobilization with movement lateral glide, which you can see in the pictures before you, where you're basically stretching the soft tissues and the ligaments around the lateral aspect of the elbow. They were given 8 treatments, 30 minutes at a time over a period of 6 weeks. the patients were recruited with the right characteristics and had their tennis elbow for what is now known as the mean duration of around about 26 weeks. So none of them were acute, they all were reasonably chronic. Now, I'm sorry about the colors on the slides. I'll just talk you through the bar graph that's in front of you. So on the very left-hand side, you can see that that left-hand blue bar is showing that the percentage success is sitting at about 75%, and that is for the cortisone group. And this is at week 3 after the trial had finished. Now you can see that in the orange bar, which is the wait and see, and the next blue bar, which is the physiotherapy, that they haven't really made much impact on this patient's success in that first 3 weeks. By week 6, you can see that the physiotherapy group now is up to 60%, and the cortisone group's sitting at about 80%. But by week 12, the physiotherapy group has made a much bigger impact. The wait and see group is starting to make some progress in the orange bar. And by 52 weeks, the physiotherapy group and the wait and see group are doing much better than the cortisone. Now, I was talking to one of my GP colleagues in the weekend, and she was saying to me, well, we get a lot of pressure from the patients to have a cortisone. And I can see that because you get this immediate response within the first 6 weeks. This person's tennis elbow pain is certainly feeling a lot better. Sadly, though, they're going to have another one because it doesn't do much good in the long term. So I'm going to make the suggestion to you that rather than rushing into the patient's desire straight away to have a cortisone, that they're given an opportunity to have at least 6 weeks of physiotherapy with this MWM and exercise approach that I'm going to show you. If they do not show a significant improvement within that 6-week mark, I would suggest they should potentially have a cortisone and then come back and finish off the physiotherapy to get the strength back in their forearm. So there's been a couple of follow-up studies to this Leanne Bissett paper to look at what's happening in the long run. And it would appear that the cortisone becomes less and less helpful over time, and that physiotherapy becomes a little bit more helpful. And most importantly, in an economic analysis, cortisone is seen as quite a poor outcome, and physiotherapy and exercise is seen as a much better outcome. So as it says on this slide, physiotherapy, not corticosteroid, is a first-line intervention for epicondylalgia. And I think the reason for that is because whilst we don't completely understand the total impact of corticosteroid, it does have a pretty detrimental effect on collagen healing. And that has a huge impact on the next phase of tennis elbow management, which sits around the ability to manage load. So there's a very elegant model of understanding load in tendon from Jill Cook. And normal tendon is resilient, it takes load, it does all the activities that we do during the day. But if we do increase the load, then we start off with a process which is called a reactive tendinopathy. Now, this is where the person starts to develop some discomfort, probably not enough to yet consult a medical practitioner. They probably beaver away with their activities, and if they ignore this reactive phase and carry on, the tendon starts to go into a period of disrepair where we start to see the collagen change from type 1 collagen into type 2 and 3, and its ability to take load is getting less and less. If we don't do something in this tendon disrepair phase, then the tendon starts to make some quite significant changes. We get a lot more ground substance in the tendon, and the tendon's ability to take load is then very poorly tolerated. Now, if you catch these patients between the tendon disrepair and the reactive phase, then most of these tendon changes are reversible, and that's why they need to go and continue to do their exercises to get back into the normal tendon structure. So how does physiotherapy work to change tendon? So this is by a process called mechanotransduction, where the loading parameters going through the tendon and the shear forces that go through the tendon put a process through the tenocyte, which is on this slide shown as that little capsulous type structure. So the squeezing and the loading of the tendon with exercises causes a sort of protein MRA process to be undertaken, and we grow better tendon and more tenocytes. And the cortisone doesn't help to facilitate that process, and you just end up with a pretty unhappy tendon. So in the next few slides, I've got some exercises that we found useful for managing tennis elbow. Some of these are specific exercises for the common extensor tendon, but doing simple resisted exercises in radial and ulnar deviation. In this particular slide, I'd really like to highlight the benefit of the triceps. Now, in the tennis elbow patients I've seen, when you've had tennis elbow for quite a while, your triceps doesn't function particularly well. And I liken this to someone who's had a painful knee and their quadriceps start to function quite poorly. So I think the elbow is the same. And often the problem we've had with exercises is we've focused only on the common extensor tendon muscles and not on the more global muscles. So encouraging patients to take a more global approach to their pain by working the triceps and the scapular stabilizers gives them a much better kinetic chain rehabilitation program. And when you think about it, if they're holding a hammer, for example, as a builder, all the builder's interested in is holding the hammer. He's not thinking about his shoulder and his trunk muscles, but those are equally important into taking the load off those small muscles in the forearm, so it's shared more equally around the kinetic chain. So other activities for the trunk muscles, the latissimus dorsi, bench press muscles to get the muscles around the front. So you'll see from these pictures that it's a very global approach to treating something that's got a very local pain generator. And then biceps curls and forearm flexion and extension exercises. So this makes it a little bit more interesting and gives people something to do, which means they're not thinking as much about their elbow, they're thinking more about their whole forearm and trunk musculature. So those are some helpful clues around the tennis elbow group. I think trying to get rid of that cortisone early, but getting them into some good rehab. If you think they might respond to a cortisone, the other option you've got is to think about acupuncture as an alternative. Some of your patients will have also had autologous blood injections, and they have a slightly better impact probably than the cortisone. They don't harm the tissue the same way. But I think that what people are missing is that if they don't do the exercises, they're not creating good quality tendon in the long term, which means they're going to become a recurrent tennis elbow patient. So we're moving quite well through this into the last topic that I was asked to talk about tonight, which is OA, hip and knee. Now, this is a growing problem. Whilst I have some statistics on this slide from Australia, the reason I've left those there is because New Zealand pretty much mirrors that. 1 in 6 Australians have osteoarthritis. 1 in 6 New Zealanders have osteoarthritis. And so worldwide, we're seeing more and more people having an osteoarthritic presentation. And perhaps it's useful for me at the start to have a little bit of a plug for the language. We've all been trained in different paradigms, and unfortunately the paradigm for osteoarthritis is the word, it's a degenerative disease. And this is a pretty nocebo language. I don't think it's helpful for patients to understand the trajectory of this disease in the sense that it's not something their joints are going to crumble away and they're going to be disabled for their life. It's an active disease process. And I think the better language, which comes from a very good rheumatologist in Australia, David Hunter, is we would better to explain to patients that these are age-related changes. So I quite like those words. We all have wrinkles. They are age-related changes. We don't stress too much about them. They're not going to cause us as much pain as osteoarthritis, though. But I think patients understanding that this is a relatively normal process. And in those people that have had trauma to their joints, they have accelerated some of those age-related changes. So I think that's perhaps something to consider how you talk to patients about what's going on with their OA. There are quite a few myths that I think all of us have probably bought into at some point in time, and the lay public certainly has some of these well embedded in their minds. And this is a paper from a colleague of mine, Dan O'Brien, talking about the time to bust the common misconceptions around OA. It's not just an old person's disease. It's not just joint wear and tear. The worse the imaging looks, the worse the joint is. It's not true. We can see some pretty horrendous x-rays and people still functioning very highly, and vice versa. Some people have called it a cold arthritis, not an inflammatory arthritis, but it definitely fluctuates and has periods of time when it's good and others where it's a lot better. There's a lot of rhetoric that considers treatment is not effectual and the only solution is a joint replacement. is discussing weight loss with people outside my scope. I think some physios certainly feel a little bit challenged having a conversation around that. I think the general practitioner would probably be less worried by that. And for a lot of people, that joint replacement is the only way out. So there are a number of educational platforms you can give patients information to just undo some of these myths. And so I've given you a website there, trekeducation.org.knee health. These are really nice things to show patients that some of the myths they may be living with are not necessarily true, and they can do a lot more for themselves than perhaps they thought. And so the high value care for osteoarthritis, whether it's in the hip or knee, is education, exercise, and physical activity. It doesn't really matter what you do as long as you don't do too much. Weight loss can make a huge difference. 5 kilograms can take quite a lot of pain out of the knee if you lose that. And for some people, we do know that a joint replacement is appropriate. But of course, there is a problem with those who can get it. And even in New Zealand, if we look at these statistics from the Joint Registry, we can see that there are plenty of people on a wait list. There are 20,000 New Zealanders right now waiting to have a joint replacement. So one of my messages tonight is, can we work better together between physiotherapy and general practice to make sure that people get the right trajectory and don't end up sitting in a waiting room for a surgeon where they may or may not get a joint replacement anyway. Here is another really good resource for patients. You can get this from a website at AUT called ALARA, or you can get this from Arthritis New Zealand. There are New Zealand-specific booklets on osteoarthritis written for patients. So these are really helpful resources to share with your clients. They're freely available, and you can download them for your patients, or the patients can go to the website. So in terms of where physiotherapy sits, there's a number of things that we look at, and particularly with my interest in the knee, the things I found when I was looking at this topic is there is reduced muscle strength, there's decreased range of motion in the knee joint, reduced fitness because you can't do as much as you used to do, you put on more weight because you couldn't do it like you used to do, and a lot of people are very psychologically distressed by the trajectory, which is unfortunately fed into by some of those myths. Treatment options, as we know, can be medication, and there is still a good place for medication, but some people get a sore stomach. Cortisone, there's a number of studies which I think are very harmful to an arthritic joint. They accelerate the cartilage deterioration, so they're just on a faster trajectory to something more severe like a joint replacement. But physical therapies are perhaps not as well utilized as we could, and as I said, we've got an issue with potentially making sure we get the right people to the right surgeon for the right surgery. So we need to explore different ways to manage this condition. Physical therapy does offer all of the things that can reduce some of the burden of this: strengthening exercises, range of motion, and gait re-education and support as people go through this journey. I published a paper some years ago, though, saying, did people get this when they got to a medical practitioner? And the short answer is not as many as we would like. So up to 50% of people got some advice around how to manage this, and the rest didn't really get anything that was useful for them other than perhaps a medication to guide them forward. So what does the evidence tell us about the management? This is a study done by a colleague of mine, Haxby, Abbott and Otago, the MOA study. This was, again, a multi-center randomized control trial where we had the same sort of format as the gel headache study: a usual care group, a usual care plus physiotherapy, a usual care plus physiotherapy, and exercise, manual therapy plus exercise. And the outcome of this study is that the exercise group and the manual therapy group were the most effective compared to usual care, but they weren't better combined. So that tells us that some patients will be driven by stiffness and they need more manual therapy, and some people are driven by range of motion and need more exercises to strengthen their knee. But I still think overall the combination of the two is quite helpful. But again, they did a cost analysis study on this and felt that the physiotherapy was still more effective than the wait and see approach. Now, another interesting development which is helping to address this significant wait list is how we can move people better through the system. So one of my doctoral students, Jennifer Stillwell, just completed the study in Tauranga Hospital area. Some of you may have been part of this, where instead of the general practitioner sending someone directly to orthopedics where they may or may not be appropriate for a total knee joint replacement, they were asked to see a highly skilled physiotherapist to triage them in a much shorter time frame than seeing the orthopedic surgeon. They were then offered a range of things: physiotherapy, pain management, an orthopedic specialist referral, or community rehab. And what this study showed is that the patients who were listed for surgery by the physiotherapist had 80% concordance with the surgeon. So they were the right patient to be there at the right time. But one of the challenges with this, as you all know, is that osteoarthritis is not funded for physiotherapy care. So whilst this looks like the sort of perfect trajectory, and if my patient doesn't need surgery, can they get into a good rehab program? The answer is they have to pay for it. But I would like to suggest that even 1 or 2 visits that they had to pay for to give them some advice and a management plan would still be very valuable for these people to understand their trajectory if they're not appropriate for surgery. And some people don't want surgery, they'd rather have another plan. So this is now being tried to be rolled out nationwide, where there is a bit more funding coming for physiotherapy. So in summary, OA is a very common condition. It's increasing in the communities. I think we need to recommend an active approach with only a relatively small number needing a joint replacement. I'd like to recommend that perhaps you get to know your physiotherapist a little bit better, close to you if you haven't already got a strong relationship with them, and perhaps develop a plan of attack as to how to manage this increasing group of patients. But as we know, cost is a barrier, and even a small group of a bit of treatment could be of some value. So just my final words to wrap up this evening before we take some questions. I think physiotherapists generally do have good skills in musculoskeletal assessment and treatment. There are now systems in New Zealand that are looking to increase physiotherapists doing triage with advanced practice physiotherapy skills. And there are things that some of you may be aware of, like integrated care musculoskeletal, which is being rolled out by ACC. And that's using physiotherapists to triage some of these patients into the system. So perhaps it would be helpful after this talk tonight, if you've got a bit more of a sense of what physiotherapy might do to help your patients, that there's an opportunity to have a conversation with your physiotherapy colleagues. I would equally admit that the physiotherapy colleagues need to have a relationship with you guys. It's not one-way traffic. But between the 2 groups, I think we can see a much better trajectory for patients. So thank you very much for listening on a Tuesday evening, and I'm very happy to take questions at this time.
Thank you so much, Duncan. That was heaps to cover and not much time. So that was awesome, and good to see some of the research behind these recommendations. So we've got a bunch of questions coming in. So guys, just flick your questions in the Q&A chat, and we'll try and get through as many as we can. Now we've got a couple of questions about medicines, so I'll just get one of those out of the way, because our focus tonight is about non-medicine interventions. Now, orphenadrine or Norflex is so common, I guess, to be prescribed and potentially asked for from patients with acute musculoskeletal pain. Duncan, do you have any thoughts on whether this is helpful?
If you have true muscle spasm, which is often a very highly protective mechanism where there is some quite significant trauma, such I've seen 3 or 4 patients with, say, fracture dislocation to their neck walk into my clinic. I couldn't move these people's necks at all, which was a good thing because it saved them. There may be a sense that some Norflex would settle them down a bit and take some of the pain out of that. The trap is, if you go back to one of those presentations I gave with someone who's got an acute lateral shift of the spine, there's often people prescribe Norflex for that. Now, it's quite difficult to understand how muscle spasm is creating that deformity, because let's say the pain's on the right-hand side of their back, they will shift to the left. But the muscles on the right are actually longer, they're not shorter. Spasm creates tightness and shortness. So these people will often be given Norflex on the premise that the muscle spasm is making their back go crooked. These people have a mechanical event, they need movement, they need physiotherapy, they need to be straightened up and put into extension. So in those cases, Norflex is of no value. So I think you've got to assess the level of spasm, true spasm, not guarding. Muscle guarding is normal with musculoskeletal pain. It's just a bit of overactivity in the muscle. I think Norflex is too strong for that. Getting some good pain relief, the usual rest, ice, compression type drills, good simple Panadol analgesia is far more effective at getting these people comfortable to move rather than putting them on Norflex.
And Duncan, with that lateral shift with back pain, how can we clinically assess someone to see if they've got that?
So you just have to take the shirt off and you'll see it. It's pretty obvious. They'll be walking in quite disabled. They can usually flex forward reasonably well, but they can usually have a significant block of movement into lumbar extension and side bending to the side that's painful. Those people can benefit from some simple analgesia again, but a skilled physiotherapist will have that person reasonably straight and walking out the door upright within a treatment session. They do resolve naturally within about 72 hours, but most people are pretty distressed that they're crooked for that period of time, so it's good to get them in and get them straight as quickly as they can. And all undergraduate physiotherapists and certainly at our university are trained to take that McKenzie approach for that particular presentation.
Cool. Awesome. Thanks, Duncan. Now, is there any effectiveness of creams such as deep heat Voltaren gel for knee, back, elbow pain?
I think there's some evidence for the rub-on non-steroidals, but I'm not so sure about the deep heat. Having said that, though, if the patient is given the message that this is going to help to improve their discomfort, and then they can do something active movement-wise because the pain is a bit less, then I think that's a good thing. I think what we need to be careful with, though, from a simple physiological healing perspective is people rubbing deep heat on their sore back and then sitting in a spa pool. They're going to feel great while they're in there, but they're going to feel pretty rubbish when they get out. So these people need to understand that they've got an inflammatory process that's bleeding. The tissues need some time, protectiveness to get them underway, but putting those sort of things on whilst they're temporarily helpful are in the long term not that helpful.
Duncan, you mentioned with acute pain going from kind of the chemical inflammatory phase to the mechanical phase, and that chemical phase is where, say, our medicines that we can prescribe might be more useful, whereas mechanical is when your PT comes in. Clinically, or if we're assessing or talking to someone, what kind of things might suggest to us that they've gone from one phase to another?
So if you've got an acute chemical reaction from an injury, which is not if we rule out the serious ones, you haven't got a fracture, you haven't got a tumor, we're quite comfortable that you're in a space where you're going to be pretty uncomfortable in the next little while. That presentation at that stage is probably going to look a little bit more like the pain is more constant. So 24-hour pain, not sleeping well, not finding a position that's helpful. That's where the chemistry needs to be managed. And I call those people my first aid patients. I just protect them, give them a good advice about things not to be aggravating, take your medication, and you're going to wait. And in a couple of days, things are going to look a little bit better. And by the time it starts to look like I can find a comfortable position now, I'm only sure when I do these movements, that's now mechanical. And that's when they should be now engaging more actively in their rehabilitation, starting to move better. So I don't mind that those people don't come acutely to physiotherapy, except for those acute shifts, they need to go early. The rest of them can afford to wait. And that sits well with the guidelines from just about every country in the world. Reassurance, medication, stay active, don't do silly things to hurt it again, and we'll see how you go in a few days. That's totally fine.
Oh, that's really helpful. Thank you, Duncan. Now, we've got a question here. Are eccentric wrist extension exercises still helpful for tennis elbow?
100%.
If they are, can you tell us what those are?
So the simplest way to do that is basically to put a weight in the hand and let if you take your non-affected hand and lift the wrist into extension and then slowly lower the hand whilst you're carrying the weight.
I need to move your arm up a little bit, Duncan.
Sorry, I'm just
thank you.
Moving my hand down under the load. That's an eccentric exercise. I can do that with my elbow bent, and I can progress to doing it with my elbow straight. Eccentric exercises were very much the flavour of any tendon problem for a number of years. I'd just like to stress to all the listeners tonight that muscle has to work through a range of things, starting with isometric exercises, concentric exercises, then eccentric, and then under load. So just throwing some eccentric exercises at someone without taking them through a progression of load is not helpful, and people get over it and they get tired of doing the same exercise without having any improvement. So the exercises that I had on the slides tonight give people a lot more activity to do, which is more interesting, and they're inadvertently doing eccentric exercises without thinking about it. So it's quite helpful.
We have a question here about dry needling, that it could be very effective for tennis elbow in kind of a subacute or chronic case. And in an acute severe case of tennis elbow or other pain, would you recommend it?
I think dry needling and acupuncture generally are not too dissimilar. It's slightly different philosophical approaches, of course. But again, if that's a better option than having a cortisone, then I would strongly recommend that. Some cultures clearly have quite strong faith in acupuncture as a source of improvement. I think if you put any of those things into a bucket of, I'm trying to get the pain down so that you can then commence your rehab, then I'm okay with that. So if the patient responds to dry needling and then they get on and do their loading exercises, that's a good trajectory.
Duncan, which patients might you refer, or might we refer, I guess, directly to an MDT pain service, e.g. ACC pain triage?
So if we go to the Start Back tool, and you've got someone who's filling out those 9 questions, and the bottom 6 questions are heavily focused on, I don't feel good about my back, it's going to break, I'm worried about doing anything, I'm not engaging in activities. And that can happen when you're acute, for sure. But if that's how you look at your pain more of the time, and you've had a lot of recurrent back pain, or your back pain has become more chronic and hasn't really gone away, then that person needs a completely different approach. And the MDT pain services are exactly for those people. The tricky thing with primary care, when you've got someone who's had a history and maybe a patient you've seen many times over who has an acute episode and then keeps coming back, but the episodes between the episodes, they're not too bad. I wouldn't be rushing them off to MDT. But if this person is really changing their whole lifestyle, they're disengaging, they're not going to go to work, then that person needs to have quite a bit of psychological support to understand that, for example, that pain does not equal harm, that they've had this pain, their brain's reconstructed a new mechanism for why the pain's there. And that's something that's very complex and needs more than one health professional to manage it. So it's trying to weed out those people who are just pretty grumpy now, but it'll get better, versus those that are perpetually grumpy and don't want to get better or have other barriers to getting better that need a different approach.
Now, we've got a question here, Duncan, around whether you could provide us with some quick range of movement maneuvers that a GP could administer in our clinic before sending them to a physio. Now, you mentioned those McKenzie exercises. Are those things that we could, that looks like 5 or 6 quite simple things? Is that something we could print off and say to a patient, hey, this is evidence-based, give this a go, or even give them a demo of some for back pain?
So the joys of the internet is you can probably get most of them off the internet quite easily if you put in McKenzie exercises. But McKenzie did write a book. He wrote 2 books, actually. One was called Treat Your Own Back, and the other one was called Treat Your Own Neck. Now, the Treat Your Own Back book has all of those exercises in there. It's got very good guidance as to what the expectation is, because some people, when they've got a sore and acute back and they know that it hurts to bend backwards, that's the last thing they want to do. But McKenzie quite quickly figured out that if you got the maneuvers right and listened to the pain, and the pain came out of your leg and into your back, that was hugely predictive of a good outcome. So even in an assessment from a general practitioner, if you got the person to bend forward 3 or 4 times and the pain's traveling from the back into the leg, that's not the right direction. If you then take them through some extension exercises, and the shift is a bit tricky to manage if you haven't been used to that, but if in the simplest versions, if they find that although extension was a little bit uncomfortable to start with, if they persevered, that the pain started to retrench back into the back, they're on the right track. And a lot of people can manage that. We've all been weekend warriors and done stuff where we've come in from, say, building a deck, and we have difficulty straightening up. What we probably don't do is lie on the floor and do some back extensions to try and get the normal mobility back into our spine soon enough. So the next day you go back and do it again, now you've got a more severe type of discomfort. So trying to teach people how to manage their trajectory can be done. So Treat Your Own Back and Treat Your Own Neck are very good resources people can buy from the bookshop, or most of those exercises, I'm pretty sure you could probably find them online.
Is there an equivalent of McKenzie, the McKenzie set for other joints, Duncan?
His general philosophy was that once you understood the different parts of the problem, you could probably manage it yourself. We go back and reflect, for example, the symptomatic stiffness group. So let's say you injured your knee 6 weeks ago. It was pretty swollen and sore, but over time it slowly responded to some ice and some Panadol. But you've noticed that you've lost knee extension. It's a bit stiff. Now, by taking that McKenzie philosophy, you can start to push yourself into extension. At 6 weeks, unless you've got a meniscal injury, that will be caused by some tightening of the ligaments around your knee. Therefore, stretching that tissue as the collagen heals is totally the right approach. And whilst it'll be a little bit uncomfortable, the more you do it, the less pain you get. So that his whole philosophy was endeavouring to get patients to take a bit more control, understand where they were in the healing process, and then apply load and exercise to their tissues to normalise them. And a lot of things will go well with that. And if the patient's struggling with that, that's a good example of where the physiotherapist might need some skills to do some mobilisation, change the stretching and the exercises and the loading so the patient sees a good resolution. So that symptomatic stiffness group can be self-managed with some good advice.
Duncan, what might be the effectiveness of using PRP instead of CSI, along with doing physiotherapy in tennis elbow or along with manual therapy? And what is CSI? I don't know that.
So that's corticosteroid injection versus PRP. So yeah, I think the jury's still a bit out on that, to be honest. Some patients do quite well with PRP. Other patients find it quite a painful procedure, and I wonder if the reason it got better because the pain from that was worse than the pain they had. So maybe there's a counter irritant going on. But at the same time, I think that's where, if we're talking about working collaboratively, the sports physicians are pretty good on that stuff. And I would always defer to a sports physician for the ability to use PRP. They will then almost invariably say you must go back to physiotherapy and continuing the loading program, because that's the bit that's missed. And so whether it's a corticosteroid, acupuncture, PRP, in that acute in that early painful stage where the symptoms are not resolving, then you've got to get that under control, and then you've got to move into the loading. So the diagram I had on the continuum of tendon by Jill Cook, that's what patients need to understand. They might be in this reactive phase. It's got to settle down a bit, take the load off for a bit. Rest is not helpful. Once they've started to come back in, they've got to load accordingly. Managing load with patients is in a gripping activity for tennis elbow is very difficult, because we've all got to pick up knives and forks and eat and do things. It's hard to rest an elbow, but patients need to understand the loading parameters that they're in. And that's where I wouldn't expect the GP to take someone through a 6 to 12 week loading program, but I'd expect a physiotherapist to take them through that.
Cool. Is there any role in diet in helping musculoskeletal pain, Duncan?
If we go to the OA group, there's if we think about load's a fascinating topic. We could probably talk about that all night. If you think about your articular cartilage, then it's taking load all day, every day. If you put on 20 kilograms of weight through a variety of reasons, you've now probably quadrupled the amount of load that's going through that knee joint. So it's not surprising that it starts to get a bit grumpy, because the load trajectory didn't have time to adapt. And so if you take that same philosophy around managing tendon, then you have to change the load. So one way that some patients might be best to manage the load is to reduce some weight. Once they've started to reduce the weight, then they can do activities such as swimming and cycling, which create nice movement to the joint, which is quite helpful. And as they get a bit better, then they can introduce load through weight-bearing exercises. So that's one of the ironies of OA, is the same exercise that you thought was painful could actually be your therapy. You just have to change the volume. So where you might have walked around the block for 40 minutes and got a really grumpy knee, if you change the load trajectory, you could probably walk for 10 minutes and slowly build it up. And within maybe 6 or 8 weeks, you might be back walking around the block for 40 minutes. So these are things which, again, physios have quite good skills at trying to manage that. But from a medical perspective, I don't think any weight-bearing joint is benefited by having more weight than is physiologically necessary. So it's a tricky conversation. I get it. But I think, again, there's lots of resources out there trying to change the patient's view on what that means. But if you can sell it to them that, hey, look, your knee is going to be much better for you losing a bit of weight. And I had a story from one of my physio colleagues who sold that story to a patient. She lost 20 or 30 kilos and pretty much turned into a gym junkie, because she realized this was her opportunity to be healthy for herself. Now, that's not everybody's trajectory, but at least it's starting the conversation.
Duncan, what are your thoughts on shockwave therapy? Is there anything that it's more or less effective for?
If you look at some of these systematic reviews that have incorporated shockwave therapies, not a lot of strong evidence for it. It's quite expensive. I don't think it's particularly comfortable to have done on elbows and various other parts of the body, plantar fascia. But again, I just have to re-emphasize that these things, if you don't do the loading, it's just another quick pain relieving thing. So you've got to sell it to someone. Look, if they did respond to shockwave therapy, that's great. That's part A. Now your pain's gone. Now you've got to do part B. Otherwise, it'll come back. And so that loading parameter with the exercises is the critical bit. And I know that means people have got to do something, but it isn't that hard if you sell it to them.
There's certainly a big market for quick fixes, isn't there?
Always, yeah.
Now, Duncan, in just a brief case example, if there's an older person that has degenerative scoliosis and a spinal stenosis, and say there's no surgery for it, and someone has bilateral posterior thigh pain, like a kind of radicular pain, what kind of non-pharmacological management might be helpful for that person?
Yeah, that's a pretty interesting case. That person may respond to some unloaded exercise. There's a bit of research, particularly around spinal stenosis, for treadmill training in a weighted belt. Now, not all gyms will have that, but at least it keeps them walking. Adopting some postures that are put them perhaps in a little bit more flexion. So, for example, some people with spinal stenosis can't walk. They get that same intermittent claudication, but in a slightly flexed position, they may be able to cycle. And so from that perspective, giving them some other activity options which don't put them into extension. The scoliosis is more challenging because, of course, if that's really changing rapidly, then that's an orthopedic surgeon review situation. But yes, there are patients, as we all know, who are got other comorbidities where a surgery is going to be very risky for them. So again, managing them with some appropriate medication plus moderated exercise is probably your best bet.
Thank you, Duncan. We've got someone comment here that if someone's not eligible for for ACC, then sometimes the disability allowance can help cover costs of physio. And Duncan and I were talking earlier about how the cost of physiotherapy can vary quite a lot. And obviously with different demographics can be more or less accessible.
One thing that might be worth suggesting to your patients, and again, this is another reason perhaps for having a bit of a chat to your physios. I've been telling physios to try and spread their load away from the ACC funding stream into other areas of greater need, and OA is a good example of that. And it is expensive, I get it. But let's say you had a one-off assessment at $60 to $80 to give a really good, thorough overview of your condition, what the trajectory might be going forward. And then you were able, at a much lesser cost, to go into a group exercise class. And there are physios who are clever enough to have figured that out, and they're running things together where it might only cost $20. I think we need to be cognizant of some cultural issues. For example, maybe running some of these classes in a marae where you've got greater ability to bring the family in. And there's a program in the Bay of Plenty called AWA, which is Activity with Arthritis, which is run by a private physiotherapy clinic. It does have some funding from the government. And there's a lovely story of a woman who was coming for her OA knee and making really good progress. She'd lost a bit of weight, her knee was going well at not great expense to her. And she said, "Oh, can I bring my husband along?" And the physio said, "Oh, has he got a sore knee as well?" And she goes, no, he's had a stroke, but I think he needs to come along and do the exercises too. So broadening out your skill set into other avenues can be really helpful, just to give a more community-based approach. And that probably keeps some of the costs down. But I would equally say I have to continually talk to my physio colleagues to say, be a bit more creative at how you reduce the cost burden until the government does make a bit more of an impact on this area.
And our last question for tonight, Duncan, do you have any tips to finding a good local physio as a primary care clinician? For example, if you're a new GP to an area. If
you just put in your Google search physiotherapist in your local area, there'll be a propensity of physios who'll pop up. You then need to look at, when you go to the staff on those websites, and have a look at what their skill set is. If they've got a postgraduate diploma in rehabilitation or musculoskeletal physiotherapy, those people will have had this type of training from me ad nauseum, so they will know what they should be doing. Some of them will have master's degrees, and some of them will have other skill sets. But I think if you can at least start by looking at what their postgraduate training will be, that will give you a bit of a heads up that they're probably offering a pretty good quality of care. There are physios that don't have postgrad training that still offer amazing care. It's probably just in the busyness of our world, trying to find some space to have a conversation about how we all could collectively manage our patients better, because that's what we're all here for. We want a good outcome. So yeah, look on the websites, Worst scenario, my email is on the front of the slides. You can drop me an email and I'll happily reply, but I don't think I want 388 emails tomorrow. But anyway, if that's helpful to everybody, just have a look at those parameters and see how you go.
No, that's awesome, Duncan. Thank you. That's a very good tip. And thank you so much for your time to present to us tonight, Duncan. There was lots in there that we can take away. And on that note, have a great evening, everyone. And thank you again, Duncan.
Great. Thanks very much, Hazel. Thanks to Goodfellow for organising it all.